I have a couple preamble comments. The first is last night's talk by Scott Leckman was just outstanding. I really enjoyed that. And it made me look at my talk a little bit differently in the sense that I think there are some aspects of what I'm going to talk about today that have some implications for advocacy. And I'm going to have to go back and figure out how do I work the things that we're working on into kind of an epic kind of talk. So the first preamble slide is here defining the problem. And in my humble opinion, and see, Mark, surgeons can use the word humble. It's okay. I don't think we're prepared to answer the most important question in global surgery. And that is, what is its value and how do you define it? And in the business world, people will talk about a value proposition. And I don't think as a community we've done a good enough job communicating that value proposition. So my second preamble slide is what I want you to remember from today. So I would consider this a moral victory if you remember these three things. So cost accounting, economic analysis, and value. And I know what you're all thinking right now. You're looking at those words, accounting and economics, and you're thinking, oh my God, this is going to be the most boring talk ever. And I will try to move it along, and I'll try to make it somewhat interesting. This is my outline, and I have four parts to talk to you about. The first is a little introduction, a little talk about concepts of money, and really how I got interested in this kind of research. I am going to talk a little bit about cost accounting, but I promise you there won't be lots of spreadsheets. And the research work that we're doing with Harvard Business School with Michael Porter and Bob Kaplan. And then the third part is the economic impact of global surgery. And then I want to tie it up in the end. I want to talk first about the concept of money in the MPH world. So I don't have an MPH, but a lot of my friends do, and a lot of the fellows actually who are sitting over here are getting their MPH, and I'll hear them talking, and I heard one of them say something, incremental cost effectiveness ratio. And it dawned on me, I have no idea what they're talking about. So just kind of their approach to talking about money, I feel like not having that background is different. They think and talk about it in a slightly different way. Now, some of the concepts overlap. Discounting is, you'll hear that in the MPH world, and I'll talk about that in just a minute. Yet our language is different, and I think that's important. And I'll tell you why. This is a little story of how I ended up doing what I'm doing. So I worked for about 5 years in Australia, and I had the good fortune of going to business school, which was one of the best professional opportunities. I thoroughly enjoyed it, and I'll tell you that my favorite course was finance. And I loved the corporate valuation section of that. So they taught us how, looking at future cash flows, future revenue flows, you can bring those into a present value and you can actually define the value of a corporation. And I thought that was just fascinating. So now fast forward about 5 or 6 years later, I'm in Boston and I'm talking to a potential donor who was an investment banker, and he had spun off some companies in the dot-com time, and he was worth several squillion dollars. And he was thinking about making a big donation, and he said, well, what's my return on investment going to be? And I started saying, well, 11% of DALYs and blah, blah, blah. And he said, John, I don't know what you're talking about. I don't know what DALYs are, and I quite frankly don't care. And that's when the little light bulb went off, and I thought about my finance course, and I said, I wonder if we could do something similar to what investment banking people do in the corporate world in global surgery. We operate on people, and we take out an appendix, or we fix a femur fracture, or we deliver a child, or we operate on someone with cancer. It'd be fantastic if we could derive a present value of what we're doing. What is the present value of future economic impact of surgery? So where do we start? Well, I'll tell you where we started. I figured we ought to start with the cost, because I know, healthcare in general, and certainly in the U.S., we do a pretty lousy job figuring out cost of care. So this is something we borrowed from Bob Kaplan. His interest is in what's called time-driven activity-based costing. Now, a little bit of a busy slide, but I'll walk you through this. Down in the bottom here, that's called a process map, and that's how patients traverse our system. So for cleft palate, that's every person that they'll come into contact with. And the color is doctor, nurse, clinical assistant, secretary, whatever. We assign a cost rate to those people, all right? Minutes of interaction, cost rate, and a total cost. So conceptually, that's how it's done. You have to understand your process map, understand how patients flow through the system, and then you time those activities, and you come up with a cost. It's very granular, a little bit labor-intensive, but very granular. And I want to show you one of our first efforts. So this is cleft palate, first 18 months of life. All right, so you can see over on the side here, CP, cleft palate. This is healthy cleft palate kids, first 18 months of life, 15K. This is cleft palate Robin. So some of you may have heard of Robin sequence. It's the kids who have the small jaw, and they can have problems with airway. And they're a little bit more expensive. And then I remember when I saw this slide, and I thought, wow, that's amazing. This is cleft palate Robin kids who require an additional procedure called a tongue lip adhesion. And that's about 6 times what the regular cleft palate kid is. And I remember when I showed this at the hospital, one of the people in the safety committee said, well, gee, John, you just kind of confirmed what we already knew, which was the Robin kids are more expensive. And I said, well, that may be true, but a priori, I didn't know it was 6 times more expensive. I mean, I would have bought 30%, 40%, 50%. I really had no idea. So I think the quantity is as important as the direction. The other thing I'll tell you is that 40% of the cost for these kids in the first 18 months of their life is in the ICU. So if you're going to decrease the cost of care for Robin kids who require this procedure, you're going to have to attack the ICU. And the other thing, now that in the U.S. we're talking about bundled payments, boy, if you're a hospital and you're trying to bundle cleft palate care, you better know, the difference between this and how to negotiate that. So I have a couple more examples. I give a brief overview at their course, and this is from my January talk. This is my day job. So I'm a pediatric plastic surgeon, and on any given day I might take care of a child with a nevus or a kid with deformational plagiocephaly. So that's the flatness they get in their head because they're sleeping on their back, and you just put a cute little helmet on them and they're fine. And then this is craniosynostosis. This is more of a situation here, and I'll show you. I apologize, I can't help but show you clinical pictures because it's what I do. This is my favorite procedure. So this is a normal suture, normal suture, normal suture. That's not a normal suture, so that's fused, all right? So this is what we do. 15 or 20 minutes later, and they look pretty good. I'm just kidding, it's more than 15 or 20 minutes. So what we did is we took those 3 diagnoses and we said, let's kind of interrogate our own system and let's see how close is our Alliance accounting system in our hospital to what we would get if we did TDABC. And again, we kind of confirmed the obvious, which is that, craniosynostosis, it's more expensive than the hospital, because the hospital looks at a 99203, level 3, new patient visit, that's what it costs. But we all know that's not true. And just for interest's sake, I thought you'd like this. So this is different reimbursement from different payers, and you can see down here that square box. Do you notice that that's below everything? That's a bit of a problem, but that's like another 2-hour lecture, so I'm not going to go into that. So what we found is there were some hidden costs in certain areas of care, some hidden profits in others. And what we did is then we took a look at a couple months' worth of data. Plagiocephaly, very common, okay? Turns a profit. So we said, you know what? Let's go back and redesign our process, how we take care of these kids, and let's make it more efficient. Let's provide better information. Let's get them through the system faster. And lo and behold, let's even increase our margin on those kids. So this is an example of where that costing information helped us to change our processes of care and actually derive a better margin. This is another one I thought would be interesting to see. This is me in the old days. So I used to just work by myself in clinic, no PA, just kind of troll around and do what I could. And this was our margin with TDABC. And then with all the increasing compliance things and whatever, our department, we started to hire some PAs, and I told our team, I said, go back in TDABC, we're using it as a verb now, I said, go back in TDABC, what's happening now that we have a PA? And you can see I destroyed value by bringing that PA into the office and not really knowing what I was doing. So now what we're doing is we're going to try to have our booking templates for clinic informed by this kind of information so that we don't end up here, that we book clinics in a certain way so that we know what we're going to get, all right? All right, so that's cost. That's the denominator. Now I want to talk about the numerator, which is the economic impact. So very briefly, I want to go over this concept that we talked about in finance, which is discounting and the time value of money. So I'll illustrate this. So if I came up to my new friend here and I said, I'll give you $100 now, or I'll give it to you next year, all right? What would you prefer?
No.
Of course. Now, I'm sorry, I'm not going to give you any money, but so of course, now you intuitively understand the concept of discounting and the time value of money. So you would much rather have $100 now than 5 years from now, all right? Now, intuitively you understand that. You can actually put some math to that, and if you use 5% here, for example, $100 a year from now is worth $95.23 mathematically, if you take that interest rate. So that's all you need to know. That's discounting, that's time value of money, and that's how you value corporations with something called discounted cash flow. So here's the exercise, and I thought maybe we'd do this for the next 90 minutes or so. Is that okay? No, it's a little busy. Don't pay any attention to anything except this line and this line. All right, the horizontal and the vertical, and I'll show you what they've done. So free cash flow, they looked at these different years. They brought this into a present value. So net present value of free cash flow to the enterprise, subtracted off the debt, that's their equity value. Then they said we have total outstanding shares of 15,000. Here's our fair value of our share price. Right? So that's exactly how it's used. Discounted cash flow, bring those dollars from the future into the present, and that's how you use it. So that's fantastic, but how do we use that in global surgery? So we started with something that people trust and respect to some degree in the MPH world, which is DALYs. And I have another confession. This is my favorite equation. I love that equation, because it takes care of the discount factor and age weighting. And it's so elegant, and it works so well. And depending on I won't go into all the details, but now, unfortunately, the Lancet came out with the new GBD stuff, and they decided for some odd reason that they're not going to do this. But as you can probably tell from the way I'm talking about this, I'm not paying any attention to that, because you can't talk about money and not discount it. So, I mean, if there are things in the MPH world that they can do without discounting their DALYs, more power to you. But if you're going to talk about money, you got to discount it. So this is what we did. Our goal was to take DALYs, averted by surgery, use two different methods, and I'll explain those briefly, to translate DALYs into dollars. So the first concept is called the human capital approach. Jeff Sachs, the economist, you've probably heard about him. His thesis is that people are basically worth what they contribute to a national economy. All right, so GNI per capita. So if you lose a DALY, if you lose a year of your life, that's whatever the GNI per capita is. All right, that's the human capital approach, and that's kind of the low end of the sphere that I'm going to show you. It gives you lower numbers, more conservative numbers. This is very interesting. Value of Statistical Life, exciting development by Thomas Schelling. You can see, this is Thomas, you can see how excited he is about that actually. Based on 50 years of economic literature. And this is based, for those of you who had an economics class in college, you probably remember people talking about the willingness to pay for certain things, and this is the principle that it uses. So what are human beings willing to pay to reduce the risk of mortality, all right? And in case you're wondering, it's actually used quite a bit. So the EPA, they use this all the time. So if they're going to clean up a river or do something, they'll value that intervention using VSL, all right? So it's very well accepted, particularly in environmental economics. The reason that I got onto this is that my brother-in-law is an environmental economist at Duke, and so he was telling me about how this is used, and we got talking and said, hey, why don't we use this to value what's going on in global surgery? So that's how we got there. So it's really quite straightforward, simple formula. You just plug it in there, and that's all you have to do. So another exercise we could do. Now don't pay any attention to that, because actually that equation is right here. So we took the cleft incidence in Sub-Saharan Africa. We figured out how many DALYs that would equate to based on accepted cleft incidence, and converted that to dollars, both in the human capital approach and in that VSL approach. And I want you to take a look here. So the total DALYs would be 263,000. Using the human capital approach, which gives you lower numbers, that was 425 million. VSL, 5.3 billion. Now let me be clear, that's 1 year, okay? That's kids born in 1 year. That's the present value of the future economic impact brought to today, okay? So think about that just for a minute, because This is a vertical intervention. All right, let's add that to appendicitis and a femur fracture and a safe delivery and cancer surgery, and let's start adding up all the vertical interventions. Even if you use the human capital approach, which is the most conservative, that gets to real money pretty soon, all right? We looked at obstructed labor, speaking of labor, and we did something similar but a little different. We looked at the economic benefit, estimated the cost to provide the necessary cesarean deliveries in a number of low and middle income countries. We got this from WHO data, calculated the cost per DALY averted, and a benefit to cost ratio. And on this busy slide, just look at those three areas there, and in particular down here. So on average, the benefit to cost ratio was 6 to 1, which is not bad. In terms of conclusions, I would say this. Research into burden and access and outcomes, absolutely necessary, got to keep doing it, but it's not sufficient in, again, my humble opinion, to advance our cause in terms of defining our value proposition. I think we need to do it in terms that maybe some people in the business world understand. Like it or not, money and cost drive policy decisions everywhere in every country. Fortunately for us, surgery is a good financial investment, and we're seeing this more and more, and there's more being published. A number of the posters here I noted were talking about cost effectiveness, and I'm glad to see that. I think our community has to do a better job of defining the value proposition, and that's both the numerator, so the economic impact, and the denominator, the cost. And this does require a slightly different skill set that is normally taught in med school or surgery. But I'm glad to see there are a number of people who, in this conference, for example, have been talking about things like this, and it's obviously a skill set that our community is acquiring. So thank you for your time, and if there are any questions, be happy to entertain them.